Good afternoon. I think many of you would be there in the morning session. So we have covered glaucoma. So these are the typical cases where you know that the patient is having glaucoma and nothing else. So majority of our glaucoma practice consists of this. But as we know that eyes are like windows of your brain and your systemic diseases. So let's look at them whether they have glaucoma or they don't have glaucoma. Now, a patient, a 31-year-old male patient, IT professional, he was residing in Australia and he was referred, he came to India to visit his parents and was referred to me for glaucoma evaluation, second opinion, basically. Patient had already undergone SLT, right eye 3 times, left eye 4 times every alternate week. He was diagnosed as glaucoma there. See his refractive profile, it was -6. 6 and 6. Pressures were 16 when he came to me and sensitivity was slightly on lower side. Gonia was open, slit lamp examination was it was totally normal. These were her optic nerves. So looking at his, I can just say that these are the large optic nerves with a high CD. So I said, okay, we'll investigate and see what you exactly have. So these are his investigations. As you can see, that OCT is showing everywhere, all around red code. So is this glaucoma? Obviously not. Perimetry is normal. There is slight enlargement of the blind spot, maybe because he has high CD, that's it. And this red disease or red disease, what we call, patient definitely has high CD, as you see here 0.87, 0.87. But the most important thing is that this is away from the normal distribution what the OCT has shown. So this is a disease of what we call as a red disease. So this patient doesn't have glaucoma and he has unnecessarily undergone SLT, which was totally not indicated in this patient. So there are various signs of glaucoma. They can be dependent on ONH size, shape, vascular signs and peripapillary changes. Less critical of these signs, what we know as is high CD ratio. Disc pellar definitely is not glaucoma. Bean potting or a deep CD, deep set cup is also not glaucoma. Vessel bearing or bearing of circumlinear vessel, nasalization of vessels or laminar dot sign are all less critical signs of glaucoma. Now these are the optic nerves and we are going to see one by one whether they have glaucoma or not. Maybe you can just see and keep it in your mind to see whether they are suffering for glaucoma or not. This is the 7th and the last 8th case. Okay. So this is a patient who was referred to me for glaucoma. If you look at the disc, there is hardly any cupping. But the most important thing is these are the small cups. Again, they are like outside the normal population what a optic nerve has. So these are definitely small discs. And this is a RNFL red-free photographs. Right eye to me looks normal. Left eye, do you think it is abnormal? It's difficult to say. But now look at the history of this patient. Patient came to me for blurred vision for last 15 days. Vision was less in the left eye. Pressure was 42. And this patient had pseudoexfoliation. But the disc was like this. After obviously the corneal edema, when subsided, we took the photographs. And now these are the fields which are like totally unreliable. So instead of repeating, we said, okay, let's look at the OCT, what OCT is showing. Now here you can see that there is thinning of RNFL here, though they are small disc area is just 1.16 here. This swept source OCT also shows RGC and RNFL thinning over here. And now if you look at the optic red-free photograph here, you can see there is subtle RNFL defect superiorly and inferiorly, though the optic nerve is not showing any cupping. So this can be due to the decrease of pressure from 40 to lower teens, where there is obliteration of the cup, but the RNFL defects are still there. So the first case has glaucoma on history as well as ONH findings here. Second case, left eye here. There is slight vertical enlargement of the this thing here, but it is difficult to say whether the neurinated retinal rim has thinned out or not. RNFL, if you see red-free, there is an inferotemporal defect over here. So even if we don't subject this patient to investigations, we have diagnosis in our mind that this patient is having glaucoma in the left eye. So obviously we will help other tests to come to a conclusion and can conclude that this patient is having glaucomatous optic neuropathy. Next case, these are the CD ratios, very large discs obviously and high CD ratio. And if you see, the fields are normal, CDs are very high, hardly any RNFL thinning over there. Even in the red free there was no thinning. So again we can conclude that this patient is having high CD, high and large optic nerve heads. As you can see here, the disc area is more than 3. Next patient reported for cataract evaluation. Here, can you see there? This is a large, again a CD ratio is very high. But in the right eye, there is thinning of neuroretinal rim inferiorly. Vertical enlargement is there, and even there is a suspicion of neuroretinal rim thinning superiorly. So now, if you see the red-free photographs, here you can see that there is RNFL thinning over here, and which can be confirmed with perimetry as well as the OCT over here. So we can conclude that the right eye has glaucomatous optic neuropathy. Tessellated fundus, it is difficult to say whether these patients have glaucoma or not. So we need to investigate these patients regularly and to see whether they are developing glaucoma, especially when they have other risk factors like high pressure, thin cystity, or any defects like this. In the right eye, there are defects which are suggestive of glaucoma. So we need to keep repeating perimetry and OCT for these patients to say whether they have glaucoma. And now, if you see that this defect there, you may find out there is a subtle defect in the right eye inferiorly and a defect superiorly over here. So these are the patients need repeated certain tests and repeated follow-ups. Now this patient, a very young patient, 34-year-old male patient with came with PSC cataract, and he was advised surgery elsewhere. But look at his disc. You can see that the neuroretinal rim is thinned out everywhere, and there is all other signs of glaucoma are there. Here also you can see that the RNFL thinning is there in both the eyes, and these are the OCT and perimetry findings over here. So whether the PSC cataract will help him, definitely, but you have to explain to this patient that you have other problem going on, and when questioned repeatedly, patient described that he was using steroids for a very long time, topical steroids for allergic conjunctivitis, and this can be a burnt out glaucoma because pressure was normal that time. So we need to repeat fields and other tests for these patients before subjecting this patient to cataract. Another, a 57-year-old male patient, systemic there was nothing. Patient was using latanoprost for 12 years. Patient had perimetry done 3 times, but he didn't have any reports. You can say that right eye vision was normal, left eye was less, and pressures were normal. Nuclear sclerosis was there, and angle was open till SS. These are his optic nerves. So do you think the right eye has glaucoma or not? The disc which I had shown previously. Left eye looks fairly okay to me. What about his right eye? Can you see any RNFL defect over here? There is slight thinning of RNFL over here. So we said, okay, let's do at least perimetry. You have undergone perimetry 3 times, so let's see what it is. And this was his perimetry. So what is this now? Patient has congruous defect, which is paracentral in both the eyes. It is same. So we asked the patient to do MRI angiography, and it revealed old infarct at the posterior tip of the right occipital cortex. So this was causing the defect over here, and he didn't have glaucoma at all. So this also you have to find out whether the patient is really suffering for glaucoma or not. And this patient, Ayurvedic physician, he was diagnosed as NTG and he was on treatment, came for second opinion because he has blurred vision intermittently. Vision was 612 N12, left eye was better, and pressures were 12. Gonioscopy suggestive of angle closure, but it was few slides, 1 or 2, it's okay. So, but it was opening on compression. So we said, okay, we'll do a test for you because I couldn't find anything. And but you can see here that the optic disc has much more pallor as compared to cupping. Even the neuroretinal rim is pale over here. So we said, let us find out what. Perimetry was non-conclusive. Even the OCT was non-conclusive. So we asked the patient to do all those other parameters which we do for NTG like chest X-ray, other autoimmune markers, including MRI. So this was his MRI findings. So patient had chronic microvascular ischemic changes and he had generalized cerebral and cerebellar atrophy. So patient was having something else apart from not glaucoma. So all these patients need detailed evaluation if they are not fitting into what we call as glaucoma. There are certain comorbid situations of NPDR with glaucoma, CRVO with glaucoma. One interesting case, a patient, I just want to share, last case. This patient was referred to me for glaucoma, and when I saw the right eye disc was like this, left eye was slightly hazy but looked like glaucomatous. When we did perimetry, it was like this, and he had a decent drop of vision in the left eye. Thinking that might be wipeout or the advanced glaucoma, it was referred to me for further investigation. But we did certain procedure and patient improved to this. So what was it in the left eye? So when we checked his fundus, we could find out that there was a HST over there and a very shallow RD in the central portion. So the most important thing is that when you are looking at the ONH to find out whether the patient has glaucoma or not, don't forget to see the fundus of the patient, especially macula and retina. So always compare both eyes and look for possible signs rather than only instrument analysis. Significant defects on OCT should be matched with ONH findings and the visual field findings, and do not rely much more on color coding of the OCT results to indicate normal versus abnormal. So these are the things you should remember. Whenever there is disc pallor more than cupping, you have to look something other than glaucoma. And if the fields and the nerves should match, if not, you have to look for media opacities or retinal or macular diseases. Thank you.